Well, kia ora everyone, and welcome to today's Weber Training Teleclass lecture. Our speaker today is Dr. Kathy Dempsey, the New South Wales Chief Infection Prevention and Control Practitioner and Healthcare Associated Infection Advisor at the Clinical Excellence Commission, the lead agency for IPC across New South Wales Health Australia. Kathy has an extensive and very impressive bio. She's been a registered nurse for nearly 40 years, and of these, she has 29 years' experience in IPC. She's a credentialed expert ICP and fellow of the Australasian College for Infection Prevention and Control. She holds a master's degree and a diploma in leadership and management, multiple international certifications, and a Doctor of Public Health through the Future Leaders of Healthcare programme. Got so many letters after your name, Kathy. I'm so impressed, and I understand you've just recently added a couple more, so huge congratulations on your AM award. Kathy is a returning member to the ACIPC Board of Directors and currently sits on its Professional and Credentialing Standards Committee, as well as the Editorial Board for Infection Disease and Health, and is chair of the Science and Research Committee. She's also a member of the WHO Global IPC Network and its Public Health Emergency Working Group. Kathy led New South Wales infection prevention response to COVID-19 and contributed expertise to national and international groups and has authored numerous IPC publications. Her extensive leadership and expertise has been widely recognised, and I know she's very well known within the Australasian community. She's also received ACIPC's highest honour, the Clare Boardman Medal for Leadership in 2022. With that incredible bio, Kathy's very well placed to speak to us today on the topic of infection prevention and control response and escalation framework, evaluation and application beyond a pandemic. Thank you, Kathy. I'll hand over to you.
Yeah, thanks so much, Jane, for that very humbling introduction. Hello, everyone. I know that there may be some people here from Australia time and internationally. So hello, good afternoon, good evening, or good morning from wherever you are. Thank you for the opportunity. And yeah, I'm going to take you through, I guess, our response and escalation framework, which was really an evaluation and application beyond a pandemic. I am going to go back through some of the COVID period, and hopefully that's not triggering for some people, but I think it's important for us to reflect and really have a look at some of this. And if you look at the global context and the rationale for an IPC escalation framework, obviously the pandemic exposed a number of global variations in infection prevention and control escalation, many of which I think we all knew what the requirements were, and many ICPs had that embedded very squarely in their minds, and it was really how to get that information out. So, you know, often with IPC decision making during emergencies, it's often reactive, can be inconsistent and variable across services. A lack of a shared framework can lead to delayed escalation, over or under application of controls, and we saw a lot of that during COVID, and sometimes confusion around roles, responsibilities, and the level of authority. A formal framework supports proportional, transparent responses with clarity, consistency, and accountability. And the reason that we've kind of gone beyond that and have embedded the framework as business as usual is that it then starts to make sure that our system is rehearsed, very clearly rehearsed, and able to kind of draw on those situations. If we look at some of the numbers and drivers during COVID, you know, this was just a period between January and July of 2021, and it was looking at all of the support requests, all of the things that we looked at, SAYERS here in Australia as serious adverse events reviews, and our IMS are our incident management system incidents that are recorded. And obviously we saw an increase of those, particularly in the height of COVID. We looked at, you know, various PPE responses and a number of, you know, medication safety investigations, which really all impact on our ability to provide a response and consistent advice. We also ran hotel quarantine, and we ran infection control similar to our healthcare facilities by overlaying basically an infection control connect, so similar to the link nurse approach to quarantine. And if you look at the various things that we were being tasked with, it was around making sure that we had precautions put in place, and many of those we pulled out from existing precautions. But what we found during COVID particularly was that whilst we had a lot of guidelines in place, they didn't necessarily result in implementation or a good understanding. So we had various precaution requirements on contact, droplet, and airborne. And not that we'll get into it now, but just despite some of the criticism, infection control had always recognised the importance of droplet and the extension of droplet into airborne or aerosolization capacity, given specific and certain circumstances and the need for additional controls in those. So if we look at the design and structure of the framework that we built, that I'm showcasing here, it basically defines a graduated level of infection prevention and control response that was aligned to epidemiological risk, clinical and operational impact, workforce and system capacity. And sometimes all three were involved, and sometimes, one or a couple of those would drive the response. Each escalation level links to clear triggers for activation. It definitely defined IPC actions and specific control measures, and also provided governance and communication requirements, being an important part for infection prevention and control. It does emphasise the hierarchy of controls. However, it also ensures that the IPC actions are risk-based and proportionate. I think the issue of the hierarchy of controls can be a little complex for infection prevention control when we have our own language and our own, set of requirements when we look at, for example, stand precautions and what that entails, transmission-based precautions. Whilst hierarchy of controls are important, it's also important to ensure that we have overlay of the IPC requirements. So if we look at the timeline for a risk matrix, if you cast your mind back to sort of 2020, we were doing a lot of things very reactionary and in response to, a lot of kind of requests. We pulled, as I said, a whole heap of guidelines out of existing guidelines and made them very present and sort of front of mind for people. But we looked at, for example, drafting an original risk assessment around April. We then started to collect data to inform what that risk looked like. We then had requests to increase those risk assessment parameters for operating theatres. And then, in July, we're still kind of looking at, for example, how to apply those. Interestingly, internationally, there were many of us doing the same kind of thing. So you could go on the internet and you could put in search engines for Canada and they would have certain frameworks. You could do the UK and they would have certain frameworks, and they all tended to include, some consistent features, but their end product were often variable. So things that were consistent were that there would be a schematic system, usually a number of colours or numbers that kind of aligned with certain risk. There would be different risk levels as defined by specific indicators. There were measures that corresponded to the intensity of control needed to maintain the epi situation at each level of community control strategies, and indicators usually were updated weekly to trigger moving up or down a level, usually based on cases and hospitalizations or health system capacity. So often there were kind of your traffic light approach. So, green was around normal demand, amber was an increased demand, red was a high demand. Some frameworks, threw in another sort of level, which might have been a yellow between, for example, normal to that increase, so amber, and some even went above red and incorporated a black level. So, just bearing in mind that generally, we kind of started with the green, amber, and red. Interestingly, though, if you're looking to look at any of those frameworks that were implemented during COVID, you would be very lucky to find any, because most of them were brought in for COVID and then retired, at the end of COVID. What we've done differently is we've really tried to embed the framework as our business as usual. So, whilst we can look at varying changes based on pandemics, we can actually overlay this and apply this in outbreaks, incidents that might be occurring, seasonal variations, and you can actually apply it locally, for example, in a ward or clinic area. You can then extend that, for example, to a service provision area if you're seeing outbreaks in, for example, a specific oncology service. Then you actually can escalate through those levels. What we're finding is that this enables then staff to be really well rehearsed around how you implement and overlay the risk assessment, how you can apply that locally, and then how you can expand beyond that, so that, unfortunately, if we are in another sort of, statewide pandemic, that we've got rehearsed and experienced staff that are been used to applying this. So when you look at a complexity of changing environments, as we saw in COVID, then some of the data that starts to inform this, and can be used today, is to calculate risk, is looking at, how often you're reporting, if you've got any case definitions, for suspected cases. So you could apply this for any specific outbreak. It can be acute respiratory infection, or, for example, if you've got any increased sort of gastro type symptoms and you're looking at an infectious gastro, then you could also apply as well. You'd look at sort of testing numbers to look at whether or not you've got an increase in prevalence, estimate percentage of undetected cases. You might want to overlay your age-specific seroprevalence, looking at whether or not you can implement methods of predicting prevalence, looking at a 14-day cumulative notification. You can, again, do that by facility, service, organisation. Particularly through COVID, we obviously did that at a state and an LHD. We also look at this during our winter seasonal period, and we actually collect information around what levels organisations might be sitting at. So if we're at foundational, if we're at an increased level of alert. And you'll notice as I sort of move through, we did change our kind of green alert to foundational level, so that we really have a baseline of what the expectations are, to be able to then move between the different levels of risk, and then overlaying, obviously, the requirement for standard precautions, contact precautions, droplet precautions, or airborne. And as we get higher in those risks, then obviously you would go directly to an airborne intervention. This is really just to kind of show you some of the consultation and the iteration. So, anything that we sort of pulled together around sort of quick reference guides for any specific department. So looking at, I guess, the evolution of the framework. We started very specifically looking at emergency department, giving them a quick reference guide. really landing in the fact that most of these things apply regardless of the environment or the department you're looking at. But obviously it's important to socialise this with clinicians, making sure that we've got input from other ICPs and the clinical departments that you're actually trying to provide information for as well. This really goes through some of the clear kind of design levels around what constituted a facility risk assessment as low, and the things that we would look at are things at, the patient COVID risk. And again, you can overlay this currently for any infection. It doesn't have to be COVID. If you're in the middle of winter, for example, and you're seeing high numbers of RSV, then you would just swap out the disease for what you're currently looking at. So, but for this, we've sort of used COVID. Are there any AGPs? Occurring, or if there are any situations or interventions, for example, that would increase the risk of transmission or increase the risk of the environment, which then would relate to increase in transmission. We then sort of looked at varying sort of risk category groups and overlaid then what the requirements were for that, and then incorporate environmental cleaning if there were any specifics for operating theatres that needed to occur, and then we moved through each of the varying levels. So what a medium risk assessment would look like, and some of the additional controls for that. So as we go through the risk assessment, so if you look at medium, for example, some of the things that we focused on was looking at what the requirements were for PPE, and looking at some of the enhancement requirements. Hence why I think sometimes it's important that we kind of look at the hierarchy of controls with a level of caution. I struggle a little bit with the fact that we have the hierarchy of controls and the bottom most least effective level is PPE. But in healthcare, the first thing that we're asking our clinicians to do is to make sure that they have the appropriate PPE on. So it's really around how we improve that messaging around what the hierarchy of controls do from a work health and safety perspective versus infection prevention and control. And I think there's a little bit of a language, disproportionate language barrier between the work health and safety hierarchy of controls versus infection prevention and control, but it's how we align those together and implement those. So I think too, when we look at medium risk, we obviously look at the risk based on surveillance definition. So it's important that early on in an outbreak that you clearly look at your definitions. Again, particularly with COVID, the increased risk definitely surfaced with the increase in AGPs or AGBs. And so looking at what sort of interventions, and there was a lot of work done during COVID around particularly AGPs and where those increased risks rely on additional and enhanced precaution interventions, looking at any source control, and also any additional specific interventions that require additional control measures. And then obviously as you move through to, if you've got a facility risk assessment that's high, then again, moving through all those things that would constitute and trigger that you've got a high sort of risk level. So looking at all those parameters, and then what kind of additional enhanced things do you overlay to mitigate or control against those high risk environments. And then obviously trying to look at how you apply those, the risks, so application of risk, and really how you bring your clinicians along the ride in terms of what resources you have in place. how you've sort of gone through the risk management assessment, what kind of resources go with the implementation. And the things that we did very sort of clearly were lots of things around quick reference guides. We then had, how we apply PPE, how do you conduct a risk assessment for PPE. And I think the beauty with a lot of this is we've incorporated this now not in a COVID specific manual, but acute respiratory infection response and escalation. So we've still kept a number of these. Some of the more specific COVID ones have been archived, but you're able to actually visualize from a state perspective what we currently have in place around risk escalation for infection prevention and control. So what we have for foundational, what might trigger all these other things, and we continue to provide, I guess, updated content around what criteria sits in foundational, what sits in, a low to moderate risk, moderate to high risk, and a high risk. So you'll still find that for New South Wales, but having tried to research and look at what's currently available from, the mountain of amazing work that was done in COVID period, a lot of this is no longer available. And I think, that's why we've spent a lot of time to normalise it and put it in as part of our business as usual, and the ability to move through these various levels depending on what you're sort of faced with at any point in time. It continues to be evolved. So, we're currently reviewing the manual as we start. Usually what happens in my team is, I have great ideas at midnight and, do very rough hand drawing, and I have some very clever people that then can kind of see that vision and then put it into like frameworks that people are able to use. So we definitely started with a risk matrix that looked at kind of a green alert, which, implied that, everything was fine, and you had very limited transmission. Obviously, the problem with COVID is that we didn't see a complete eradication. We're seeing COVID kind of really establish itself, as part of our kind of, body of communicable diseases that we have to manage year in, year out, and still trying to fit as to whether or not it's seasonal, or are there certain triggers that overlay. So we have moved, and you'll see where we sort of moved to, but this is where we kind of started from. It was like early on, we kind of, particularly in New South Wales, we had very few cases. So we had areas in green. Then we started to see increased number of cases. So we didn't want to go straight to an amber alert, hence why we had really this kind of in between green and amber, so a yellow. So it's things are starting to look like there's some issues, there's some increasing. We've got a few parameters that start to tell us that, things are starting to escalate. There are some simple things that we can do in terms of protection and mitigation to hopefully uh, reduce the issue of it sort of, going to amber alert. But obviously then, particularly with community spread and when you're sort of in the midst of a pandemic, it's making sure you've got those ability to able to escalate. And you kind of can apply these, whether it be, as I said, statewide, facility-wide, service-wide. Obviously, many of this during COVID was statewide driven. What we now see during our winter period is we get it more around facility level or sometimes district level. We have some districts that have a very low threshold to go straight to yellow or amber at the beginning of winter, and a lot of that is based on preservation of staff. So they put those high controls in, and they're able to to do that. We're probably not quite sophisticated in the way that we collect what level facilities are currently on, but we are able to do that fairly manually. People contribute to an Excel spreadsheet and they provide things to us. Then it was obviously important to go through kind of each of the different levels of craft groups. What happens with patients when you're in green, amber, or red. At one period, we I guess considered the idea of purple, which some organisations had black, some countries definitely had black, some had purple. So again, it's really the colour frame. We didn't sit very long with purple because we kind of thought, if we got to red, we really need to be trying to control it at that level, but gave some clear indication of what requirements would be for different craft groups. So, all patients in hospitals, sometimes then there would be specific groups that would be concerned that they needed additional advice or additional direction. So then we'd draw those out. So, what would happen in the emergency department? What would happen if we had patients presenting directly to delivery suite and we had, for example, said that we were in amber alert? So, these are the things that we actually overlay: maternity, and pediatric patients as well. These are the kind of dashboards that we obviously used in the middle of our outbreak scenario and pandemic. We don't go to that level currently from a state perspective, but locally, these are the kind of parameters that could start to indicate a trigger for escalation. So the things that you look at is that you would look at your local transmission. So that might be your service transmission. It might be what's occurring in the ward. It might be what's occurring in the facility more generally. You then look at that in parallel with what's happening from a public health perspective, and we continue to report a weekly, I guess, respiratory and communicable infection report from public health that's released at a state basis, which provides us an indication of how we're travelling for our top kind of acute respiratory infections. So usually influenza, COVID, RSV. If there's something additional happening, there might be some additional information and intel, for example, around measles, or the hantavirus recently. So there might be just some public health information that may not be implicated specifically for New South Wales, but at least provide some background of what might be happening either at a national level, or if we're not seeing anything nationally, then if it's something internationally, then we would include that. And then obviously there's like your kind of healthcare setting specifically around that. So it's kind of community, public health level, and then around what's happening in your healthcare setting. So sites can look at this and then they start to develop their own settings that then drives how they might actually escalate. Now, some LHDs may sort of look at this and go, actually, our real trigger is, we know at winter, we start to get increased cases around here. Particularly some of our regional areas might sort of go, we know this period is really problematic to retain staff. It's important. We might go straight to an amber level as soon as we start to see public health announcements where, for example, flus are increasing or COVID levels are increasing. So then, I guess too, this is really just to give you some of the metrics that we looked at, and some of this we were able to gain from the literature, and other was really around the experience that we were seeing at the time. So if you kind of had looking at what your normal presentation was, up to sort of 590 presentations were ED presentations, for example, COVID, you'd be relatively green, up to sort of 0.5%, so 600 staff or healthcare workers, you'd still be relatively green. So you'd be considering that this would be your kind of normal seasonal kind of stuff, your number of hospitalised COVID-19, and you can shift a little bit. So these kind of are not set in stone, but some of the parameters that we originally looked at, so you can sort of start to see the things that would start to drive a trigger for escalation would be, what your ED presentations were looking like. So what those weekly look like, your healthcare worker isolation, your number of, patients of said infection in the hospital, your percentage of ED accessible beds with said infection. And obviously during this period we looked at COVID, the number of COVID-19 patients in ICU, and so if you kind of triggered above that, then you would start to look at whether or not you need to escalate. And then the final one for us was around patients ventilated. Now you could look at this and go, one or two of these are really indicative, but you might add some other parameters. But generally this is what we kind of use for the dashboard to look at this. And these were the kind of the things that we then started to populate. So looking at growth factor, again, locally you could do this if you've got good access to EPI, and working really well with your public health, reported cases, what the age distribution was, and then based on some of those, you would start to kind of, map out then whether or not you would be truly in, foundational green, a yellow, amber, or a red. We do find there's probably less formal metrics around escalation currently. The fact that they've embedded the framework sort of locally, they look at sort of average admission, presentation, healthcare worker, sick leave or absenteeism, and then overlay that with kind of community spread or community prevalence at the time. This is, again, I guess, really playing around with the different levels of matrix. And I think it really just starts to show you how advice and guidelines start to mature. So, this was kind of early on. And, whilst it was received really quite well, it then started to unpack a number of questions. And then, how you kind of move that beyond this framework. And interesting, if we looked at comparing frameworks, and this was done probably around, I think it was probably around 23, 24, while there was still access to a number of risk matrices that were available. Sorry about that. So I went sort of around Australia to have a look at, what was being used, and there were lots of variable frameworks being used. And I think the one thing that would help improve infection prevention and control is, where we can potentially streamline and provide consistent approaches. I think that builds definite confidence in the system. And I think, there was a lot of similarities with frameworks, especially, for example, if we went to, internationally, there was a lot of variation between either the levels that were provided, the amount of content in each of the levels, what constituted the levels, and definitely some of the controls were, a level of consistency. But again, I think, if we were to do this search again today, most of these frameworks would not be available at all, because, as I said, a lot of us have, a lot have been retired since COVID. And what we've tried to do is work out how we build such kind of risk escalation frameworks into our business as usual, so that we can then overlay that based on local community, and if needed be, we could then escalate if we were having statewide issues. So this is kind of really how the framework has morphed. Although we've now kind of morphed more into kind of acute respiratory infection and COVID safe. So we're looking at all respiratory infections, and rather than kind of starting with a green level, we really started with what was foundational. So we removed the green and really put it as a white level, because we didn't want to indicate that everything was okay, but it was really how the system is prepared. So making sure that, that we have a system that's prepared at any point, to be able to escalate, what that looks like for clinical and patient care, what that should look like for visitor. Unfortunately, there were a lot of interpretations during COVID around what infection control actually is said and what was interpreted, particularly for visitors and carers. So we've tried to address those issues, and then what your general principles are. And so regardless of where you are at any given time, there is an expectation that there is a foundational level of preparedness and implementation of sound and robust infection prevention and control systems, of which we have many consistent systems. So if you look at obviously the World Health Organization and the core elements for programs, there is a lot of information that is consistent, that we can draw upon to look at what our baseline should be looking like. And then obviously, what happens if you start to move through the escalation periods, and what that looks like, and at what level. Like, what does your transmission risk look like? What does clinical and patient care look like? What do visitors look like? And then what your general principles are for those areas as well. And then, obviously, when we look at, for example, the infection prevention and control issues, it's really around, what is happening with health workers and community-acquired COVID and the risk bringing into healthcare and how we manage those. Obviously, the level of staff impact and the capacity of service, whilst that's very important in the middle of a pandemic, it's equally important as you start to get surge periods, and particularly seasonal areas, impact of non-clinical areas with introduction of whether it be COVID-19 or any acute respiratory infection. There's definitely a degree of staff confidence around health worker safety, making sure that they're fully across these levels. And we've found that with the preparedness body of work that we've done on top of implementing the framework, the level of confidence from staff increases, because there's a level of consistency. We're not pulling out something different that is not rehearsed just because we've got an outbreak. We've got things that we can actually move through, obviously on a day-to-day basis, that is very specific to our environment, but also can be overlaid from a state and national perspective if needed be. HAI, COVID and acute respiratory infections continue to be an issue, and that's probably another talk around how we do surveillance and obviously record that, but making sure that we've got the ability to intervene and put controls in place. And obviously we look very closely to our Northern Hemisphere colleagues around what the experience is, which kind of helps then drive what our potential winter strategy would look like for all of these. Post-winter, obviously, we've gone BAU guides for the framework. We also have a triggers for escalation guideline that provides information around when you do need to look at escalating and what triggers would look like, and then also reporting through to the Ministry of Health. So there's obviously a level of governance around that. Vaccination and the opportunistic approach to ensure that we can capture as many patients and health workers as possible. And then obviously, our normal controls that we have in place that we continue to monitor outside of winter. and making sure that we've got communication plans for that. Um, uh, Now, we did actually go out to survey and actually ask participants to review, I guess, a number of layers of the framework in terms of, where they came from, what type of health service, and really their experience of implementing. So we did a broad survey across the system that encompassed our ICP network mostly, given they were responsible for implementing majority. We had a specialty task force, directors of clinical governance, which were responsible for ensuring implementation at a facility level, and also clinical council. We surveyed both metropolitan, rural, regional, plus also disability, aged care, primary care setting, and correctional health, and then went through different specialties, so acute care, community, primary, and really just to collate info about our outbreak management and infection prevention and control, the benefit of the framework, whether it was used locally for COVID and others, and really it helped drive development of our existing framework. And I'm not going to go sort of through all of these. There is a paper that I wrote that kind of summarizes all of this, but I guess in summary, there was a lot of benefit out of providing the system with the framework. There were obviously areas for improvement. Overall, though, it gave the system a level of confidence. It also set infection prevention, the state infection control program up as the lead agency. So again, increasing the level of confidence. We had kind of one source of truth. Any of the changes came through that area. It was implemented. The resources were implemented in their workplaces. The risk matrices provided, a level of detail that was both informative and effective. And then obviously, in terms of comments, there were a number of positive comments. We also had a number of challenges around sometimes implementation, and so things like, sometimes we had too much information, for a system that was under pressure. Hence why moving this into business as usual, you start to have a system that is well rehearsed and used to overlaying these. These escalation or risk frameworks were a little different for our system. So obviously, I think putting it as business as usual improves that. Definitely a number of improvement opportunities, and we use the opportunity to actually move through all of those. And then we also provided and collected a number of comments to move enhance that. So the application beyond the pandemic condition is that it's not disease specific, and it can be applied to seasonal respiratory, local outbreaks, emerging or novel pathogens, non-pandemic system pressures impacting IPC risks, and supports a shift from crisis-driven responses to preparedness and routine readiness. So I think that's really the key message. Governance and leadership cannot be undervalued. It really relies on strong APC leadership. It's a defined escalation authority, and definitely has executive sponsorship for that. There are a number of workforce and system benefits around being situationally aware. You've got multidisciplinary coordination, trust and transparency in decision making, and it definitely reduces the variability or the variation. So I've given the link here, which will give you to the most current. We are currently revising and updating just to see if there is, a little bit more information or any greater clarity that we can provide for this. But this is basically the framework as it sits today. And I think the key messages and take-home points really is that structured escalation frameworks strengthen IPC preparedness, and it's not just an emergency response. Pandemic-derived tools have enduring value when they're systematically evaluated and adapted. And, I think to be able to have them available beyond the pandemic cannot be undervalued. Clear thresholds, actions, and governance enable proportionate and timely IPC decisions. There's definitely a level of transparency and visibility by putting the way infection control often responds to situations that may not have been readily visible developing this. IPC must be embedded as a strategic system level function rather than a reactive specialty response. I've seen some recent information that kind of says, infection control is often silent until there's an issue. And that's not to say that we're not working very hard. In fact, we are working very hard in making sure that our systems remain responsive. But, it's important that we bring that to the forefront. And I think applying frameworks beyond pandemics support resilient learning health systems. And that's me for a wrap up. Thanks, Jane. I'm happy to move over to you for any questions. Maybe.
Jane, are you there?
Apologies, I hit the video, not the audio button. Entirely my fault. Apologies. Thanks, Kathy. That was an amazing overview of some great work on risk assessment. In all my years, I've always said that risk assessment is the heart of everything we do. I think you really nailed it with this incredible tool. I was disappointed not to see New Zealand feature on your slide comparing states and internationally, but I can confidently confirm that we used a very similar sort of traffic light approach. But you're absolutely right. A lot of these incredible tools got archived pretty quickly. And so the fact that you've kept this in place and it's become business as usual, I think is so important. What's the opportunity for putting this in place across Australia?
Yeah, I mean, I think we've got an opportunity to look at a risk framework and develop something very similar that can be inserted nationally. I mean, I currently sit on the, with the Australian Commission, and whether that's something that they could pick up or whether it's the Australian CDC. But, I think it really adds to our network as a consistent, concise, sort of evidence base. I think it's the variability that undoes infection control often. We know that it's not black and white. We know there's a lot of grey areas, but I think if you embed something like this as a sort of standard, at least even a template, then I think you kind of build into the system that preparedness, and we're kind of always ready.
Yeah, absolutely agree with that. I think that's it. And staff, as you pointed out, feel so much more comfortable knowing that there's a structured response and an approach to outbreaks at whatever level. And I mean, I also wonder about the software opportunities here. You mentioned access to EPI.
Yeah.
Is that widespread in New South Wales?
Yeah, look, I think for New South Wales, it's a challenge. I don't, for example, have EPI directly assigned to the program or the team, whereas other, similar run programs do. And I think if I was to pick gold standard, I think we should have ready access, directly appointed that we can tap into. I recently did a training exercise in Stockholm, and the ability of the EPI guys on that group were just amazing. And I think there's particularly for New South Wales, we have a gap in that space. And yeah, I agree. I think if we had software systems that you could easily tap into to be able to, do some very simple epi for us, it would drive, quicker changes, I think, in my mind.
Yeah, it's definitely a bit of a weak spot for us, I think. And it's, it really would make IPAC implementation so much easier if we had that sort of access, I think. So some great opportunities. Maybe a second doctorate, Kathy. What do you think?
I don't know. I need to get over
Don't
this
you
one.
dare.
Maybe some aspiring ICP who's really looking for something, then yeah, there's definitely a doctorate in, this. I often feel like, I kind of really just stirred the waters a little bit with some of this work, and I think there's definitely some more work to be done. So, happy to support anyone that's out there that's thinking, what could I do next? So any young budding ICPs, there's definitely work that can be done in this space.
That's great. All right. Well, thanks again, Kathy, for a great presentation. I'm sure that this will be accessed by a lot of people within our Weber training fraternity. So I look forward to receiving any comments or queries from the audience listening in. Please don't hesitate to email me. And of course, you've got Kathy's contact details as well on that final slide. So if we just look forward to some future Weber training lecture opportunities. Those are the scheduled ones for June and July. Some great topics there for us to link into. So looking forward to those. And finally, just acknowledgement and thanks to our patron sponsors of Weber Training, without whom this wouldn't be possible. So appreciate your time, Kathy, and appreciate you, the audience, for listening in